Hello everyone, welcome to the Academy of Online Radiology Education. My name is Sabrina Hsiao and I am from the George Washington School of Medicine. We will be discussing optimizing pneumothorax identification in the emergency department, exploring point-of-care ultrasound versus chest x-ray. Thank you to Sharif Ghozi for his assistance in this presentation with editing. As an overview, we will first begin by discussing the background and importance of a timely diagnosis of a pneumothorax in the emergency department. Then we will be discussing the clinical presentation of a pneumothorax and classic, important, can't miss parts of a history and physical exam. Then we will be discussing the diagnostic imaging and further discussing a relevant study, results, and key findings. And further talking about diagnostic imaging modalities, we will discuss the strengths and limitations of POCUS versus chest x-ray, and we will conclude with talking the clinical implications. Further discussing pneumothorax in the emergency department, or the ED, timely diagnosis of pneumothorax in the ED is life-saving. Thoracic injuries estimate about 25% of trauma-related deaths, with pneumothorax reported up to 40 to 50% of these cases. Delayed diagnosis can lead to tension pneumothorax, hemodynamic compromise, as well as increased morbidity and mortality. The classic presentation of pneumothorax typically starts with a history. There will be a sudden unilateral pleuritic chest pain with shortness of breath, often spontaneous and can typically be seen in a tall, thin, younger male, and often can be secondary to trauma. On the physical exam, there can be tachypnea, tachycardia, decreased chest expansion, hyperresonance on percussion, absent breath sounds on affected side, as well as some tension signs. And certainly variation exists, and it is possible that patients will present asymptomatic initially. So after you have your detailed history, physical exam, and a strong clinical suspicion, what is next? The next step is typically imaging, and there are various modalities, such as POCUS, which can provide a more rapid bedside confirmation and assessment, and a chest x-ray, and that can be used if the patient is stable or for follow-up. And a CT scan is reserved for complex or unclear cases. We will be discussing the POCUS and chest x-rays for this presentation, but of course, important to keep in mind CT scans as well for complex or unclear cases. This study from Singer and his fellow colleagues looked at over 500 trauma patients who had both POCUS and CT or thoracostomy. They compared bedside ultrasounds with expert-reviewed ultrasound chest x-rays, and they found that bedside ultrasounds had a sensitivity of about 68% and a specificity of 100%, which improved to 84% when expert-reviewed. Chest x-ray, in comparison, had only 48% sensitivity. Time to diagnosis was also faster with ultrasound, about 10 minutes compared to 17 for chest x-ray and 77 for CT. So overall, based on this study, they concluded that ultrasound was not only faster, but also more accurate for clinically significant pneumothoraxes. Ultrasound does have its limitations. It can miss small or localized pneumothoraces if the right spot is not scanned. In addition, false positives can occur in conditions such as COPD, bullous disease, or those with subcutaneous emphysema. In addition, image quality is reduced in obese patients, and the sensitivity can decrease after 24 hours as the air redistributes. And finally, it is operator dependent, meaning results can vary depending on who's doing the scan. Chest x-ray, on the other hand, remains the traditional first-line test. It's highly specific, and if you see a pneumothorax on chest x-ray, it's almost always indicative of a true pneumothorax. The positive predictive value is very high, and portable x-rays are widely available in most EDs. It's especially useful for confirmation, and unlike ultrasound, the accuracy does not depend as much on operator skill. Chest x-rays do have its limitations. For example, it is short in its sensitivity. It can miss small pneumothoraces and is less accurate when patients are imaged supine, which is the typical position after patients can be presenting in after a trauma. In addition, there are overlapping structures such as tubes and lines which can obscure the diagnosis. Furthermore, it's also slower to obtain than ultrasound, which can delay recognition and treatment. So while it's specific, it's not very sensitive, and this limits its utility in unstable patients. While the focus of this presentation was to talk about POCUS versus chest x-ray in identification of a pneumothorax, I also wanted to include some review for lung ultrasound signs for pneumothorax. As medical students are often taught the classic chest x-ray presentation and imaging associated. However, I wanted to include some lung ultrasound signs that can be indicative of a pneumothorax to kind of broaden our clinical understanding of how it can present. The main takeaways here include how early diagnosis of a pneumothorax is critical for patient survival. Chest x-rays are used most commonly in the emergency department, but are less sensitive for small pneumothoraces or for patients that are supine, such as after a trauma. For POCUS is faster and more sensitive for clinically significant pneumothoraces. However, training and supervision is vital to ensure accuracy as well as ensuring that there is no biases within the operator who is using the probe. In addition, for its clinical impact, the takeaways are that using POCUS allows faster detection of a pneumothorax, which can lead to earlier intervention and assist in trauma-related patient care. These are my references used for this presentation. Thank you to the Academy of Online Radiology Education for this platform to discuss modalities in radiology and the emergency department.